Welcome back to the podcast. I hope everyone is doing well in the run up to Christmas. Today, I'm in conversation with Dr. Mark Horowitz. Mark's a training psychiatrist, now working as a clinical research fellow at UCL. He's an associate editor of the Journal of Therapeutic Advances in Psychopharmacology, and he's edited a collection of papers about discontinuing psychotropic medication. He has a PhD in psychopharmacology and neurobiology of depression from the Institute of Psychiatry, Psychology, and Neuroscience at King's. Mark has an interest in rational prescribing and safely coming off psychiatric medication, which has been the focus of his most recent work, published in The Lancet, in JAMA Psychiatry, and the British Journal of Psychiatry, as well as the Schizophrenia Bulletin. And he also co-wrote the Maudsley Deprescribing Guidelines, a guide for clinicians about slowly helping patients come off various kinds of drugs like antidepressants, benzodiazepines, and so on. He has his own blog, markhorowitz.org, and he's written in the media about his own personal experiences with antidepressant withdrawal syndrome, something he personally experienced when he tried to come off antidepressants himself and experienced some quite serious side effects. Today, we talk about the problems of viewing depression primarily through a biomedical lens, as opposed to a more psychosocial lens, the causes of depression, the limitations of antidepressants, and those risks of withdrawal symptoms I just mentioned when stopping antidepressants. We talk about Mark's own personal experiences with this, and Mark outlines some useful principles as to how to wean off psychiatric medication safely. Some caveats to this conversation. Nothing in this podcast should be taken as direct clinical advice to anyone listening, as everyone's situation is unique. If you are taking psychiatric medication and you're considering stopping it, I would highly recommend discussing this with your prescriber in order to make a plan about doing it safely. I do suspect that Mark and I might disagree slightly in terms of the potential value of medications, at least in the short to medium term. But that being said, as I mentioned in the podcast, much of what he says and his research does match with my clinical experience. So I definitely think it's a point of view that needs to be taken quite seriously. If listeners want to learn more, I would also direct them to a podcast episode I made earlier this year in April, which is called My Thoughts on Psychiatric Medications, where I outline 7 or 8 principles to use psychiatric medications more safely, and that's a guide both for prescribers and for patients. If you want to learn more about Mark's work, you can find out more from the website I mentioned. Again, that's markhorowitz.org. In addition, as I've mentioned recently, I'm doing more talks for companies and organizations, talks about men's mental health, but also psychotherapy in general, and other interesting and useful aspects of psychology like personality theory. If you'd like me to talk for your company, team, or organization, you can email me at thinkingmindpodcast@gmail.com and put speaking inquiry in the subject line, and I'll get back to you as soon as I can. Thank you very much for listening. And now here's today's conversation with Dr. Mark Horowitz. Thank you so much for joining me.
Thanks for having me on.
We're going to talk about a few important topics today: depression, antidepressants, perhaps some of the dangers of antidepressants, and the dangers of coming off antidepressants, deprescribing. But first, I wonder if you could give us a little insight into your story and how you started to research all of these topics.
So I became interested in how hard it is to stop antidepressants after I had a very difficult time coming off my medication myself. I'm originally from Australia, but I moved to London to do a PhD in how antidepressants work and the neurobiology of depression at King's College, London. When I was finishing up my PhD in 2015, I read an article about withdrawal effects from antidepressants, and I found that quite startling because I hadn't been taught that withdrawal effects from antidepressants occurred in my previous training. And I guess I had two main thoughts. One, I had myself been on an antidepressant at that point for more than 10 years. I thought drugs that cause withdrawal also cause tolerance. Those are the flip sides of the same coin. The more accustomed you become to a drug, the more you get withdrawal from it. So I thought, what is a drug that causes tolerance doing after being on it for more than 10 years? And the second issue I thought is that drugs that cause withdrawal effects often have all sorts of other negative effects on people. Drugs like Valium or diazepam, Xanax, alprazolam, OxyContin, opioids. And so I wondered what the drug was doing. I already had concerns that I had a number of significant side effects to the drug. I had a lot of issues with daytime fatigue, with concentration and memory problems that I had diagnosed as various other disorders, including chronic fatigue syndrome and narcolepsy. But I had a vague idea that maybe it's related to the drug I'd been taking then for many years, which was escitalopram or Lexapro. And so reading about this article was a bit of a trigger for me to decide to try to come off the drug. And what I did was I read, being a very dutiful, nerdy PhD student, I went and read all the published papers about how to come off antidepressants. And they basically had the same message that coming off these drugs was pretty easy. There are brief and mild symptoms on stopping, and you can do so by halving the drug over a couple of weeks, then halving it again before stopping it. Some of those articles are written by the professors I was working with at the Institute of Psychiatry. I recognize lots of the names, of course, of the authors. And then I also went and checked on Google, because I'm a millennial, albeit a geriatric millennial these days. And there was a very different story on online groups where people said it was extremely difficult to stop antidepressants. It took them months and sometimes years. They were grinding up tablets to make liquid versions of the drug and using small syringes to make reductions. They were opening up capsules to count out beads. And people that came off these drugs quickly over a few weeks, like doctors often recommend, ended up having severe withdrawal effects, sometimes being bedbound, losing jobs, becoming extremely disabled from it. And I was a bit confused at that point because I'm a fairly institutionalized person. I've got 6 academic degrees. I'm used to listening to what professors say. So I was a bit unsure about what direction to take. And I kind of decided to split the difference and go somewhere in between those ideas. So I went a lot slower than 4 weeks, like the guidelines said at the time, the NICE guidelines, but not as slowly as people around that I read about went. And I basically came off my drug or down to very low doses over about 4 months. I used a liquid version of my drug, and I used a micropipette from the lab that I was working in at the time. So I was lucky that I had access to a cutting-edge molecular biology lab, unlike a lot of other people. When I got down to a milligram of escitalopram or Lexapro, my life basically imploded at that point. I had trouble sleeping, and I would wake up in the mornings in full-blown panic, like I was being chased by a wild animal or standing on the edge of a cliff. And that state of panic would last for about 9 or 10 hours of the day. I'd get a bit of relief in the evenings. I started running a lot to get a bit of relief from my symptoms, and I ran basically until my feet bled. I felt a bit dizzy all the time, and things around me appeared sort of unreal, a bit dreamlike. And I should say, none of those symptoms were anything like the issues that put me on the drug in the first place. I went on the drug at 21. I was in third year medical school. I was an unhappy young man, unsure about what to do with my life. I had all sorts of existential concerns. I was certainly miserable, but I never had the sort of issues, the panic attacks, the trouble sleeping that I had when I came off the drugs. It was, if what I had when I was on the drugs, when I went on the drugs originally was 3 out of 10, what I had when I came off the drugs was more like 10 out of 10. I tried to endure those symptoms for week after week, until eventually I thought, if I keep going like this, I'm not sure I can survive. I don't think I can keep living like this. And I ended up going back on the drug. I increased my dose slowly back to my original dose, and my symptoms improved over a few weeks, which I found out is quite lucky, because sometimes the symptoms don't go away so easily after you restart. And I realized at that point that I'm now back on this drug, not because it's useful to me, but because I can't get off the drug. I actually ended up quitting my job that I was doing at the time at Slam in South London. And I ended up moving back actually to Australia to my family's house because I was so shaken by the process. I went back to training for a couple of years in Australia, and then to cut a long story short, I basically decided this is quite ridiculous, really, that well, I should say, I basically then decided I'm going to come off the drug again more slowly. And this time I sort of knew who the experts were. There were these online peer support groups where people who had very similar experiences to me congregated. I sort of soon found out that it wasn't just me that had these issues. I found hundreds of people that had similar issues, and then I found tens of thousands of people. There was huge groups of people who had the same kind of very severe symptoms coming off their drugs. I decided to come off again, and this time I went to what I now consider to be the experts, the people on these peer support forums, and I followed the advice there. The advice there was basically to come off at about 10% of your dose every month, so that when you're at 20 milligrams, you come off at 2 milligrams a month. When you get down to 5 milligrams, you slow down to 0.5 milligrams per month. And that's now several years ago, I started coming off my drugs like that, and it's taken me years to come off my drugs, not just weeks. And I guess in coming off my drugs, it's improved a lot of the symptoms that I had when I was on the drugs. Things like daytime fatigue, my memory and concentration issues have all largely resolved, which has been, I guess, very upsetting for me to realize that I'd been taking a drug that had caused me so many health problems for so many years, but very relieving that I'm now getting out of that experience. And I guess I sort of thought, getting back to the ridiculous aspect of things, that I was getting better advice on how to come off my drugs from online peer support forums than from the sort of top professors in the field. And so I wrote an article about what I'd learned from these peer support forums, combined with some of the neuroimaging data that I'd come across that showed that extremely small doses of antidepressants have very large effects on the brain. And so it makes sense to go down by very small amounts at the end. And that paper was published in the Lancet Psychiatry now a few years ago, and it slowly led to changes in the guidelines in the UK, now spreading around the world a little bit. And so all my work since then has focused on how to help people safely stop antidepressants and other psychiatric drugs. And that's also led to a bit of a reevaluation of their safety and their effectiveness more widely.
Wow, that's quite a story. And in the 10 years that you were on the antidepressants, was it escitalopram 20 milligrams, I'm assuming, a day?
I think it was about 10 or 15
10 or 15
milligrams for
milligrams
most
a
of
day.
that period. Yeah.
And I assume, because this is so common and I see this all the time in my patients, your prescribing doctor didn't check in, do a regular risk benefits analysis to see during a 10-year period, should you remain on the drug or not remain on the drug, anything like that.
Yeah, that's right. I just got repeat scripts. I was in Australia for some of that time and in England for some of that time. I got repeat scripts, I think on whatever it is, 3 or 6 monthly repeats. I got to say that, I hadn't put together the side effects that I hadn't attributed them to the drugs because it has sort of been in the background for so many years. I never put it together. I should say that a GP in London, actually right next door to the Institute of Psychiatry, did say to me at some point, "You seem to be doing quite well. Have you thought about coming off the drugs?" And I wasn't very happy to hear that. I sort of said to her, "Listen, lady, I'm a psychiatry trainee. I'm doing a PhD in antidepressants. If I'm doing well, it's probably because of these drugs. It would be very, unwise to come off the drugs." So I sort of bit her head off in the same way that many people bite my head off, not just patients, but lots of other academics and psychiatrists. So there was obviously ideas in my head that it was useful for me. So I should give brownie points to that GP who did bring up the issue.
It's interesting how we can be captured by a story, isn't it? And as doctors, we often feel we're protected from this because we're ensconced in a certain scientific rationalism, or so we think. And of course, that's not entirely false, but we're still just as vulnerable as anyone else to fall in love with a certain narrative of how things go. And if I could share a quick story around this, I worked at a tertiary center, meaning a highly specialized clinic, national service that sees people from all around the UK with treatment-resistant depression. And with the best minds in the country trying to figure out what might be the appropriate way forward for someone with treatment-resistant depression. And there was one particular patient who had tried almost every drug you could think of, and they presented to the service. When I was working there, ended up referring this person to a low-cost psychotherapy clinic. They had never really had psychotherapy in their lives. They had therapy for something like 30 or 40 pounds a session, and over a 3 to 6 month period, their mood was better than it had been in something like 5 years. And that really awakened me to the dangers of hyper focusing on one small part of the story, in this case, what's going on with someone's neurotransmitters, and not taking a bird's eye view and thinking, what is going on as a whole for this individual, and what could be the other factors at play in dealing with something like depression or low mood.
I mean, it's an interesting story. It's not at all surprising to me. I hear those stories all the time. I think they're probably more common than the opposite. I mean, the way that the idea that you can fix someone's mood by affecting their neurotransmitters is a bit peculiar, to be honest. I think I've come across a very useful model, which you might have heard of from Joanna Moncrief, about how to understand what drugs do. It's about comparing a drug-centered model with a disease-centered model. A disease-centered model suggests that, that psychiatric drugs can reverse the underlying cause of a mental health problem, a little bit like the way that an antibiotic kills the bacteria causing a lung infection and therefore relieves the cough and fever. And, psychiatric drugs are often presented by acting in that way, that they can fix up the underlying neurotransmitter problems in psychiatric conditions like depression, for example. But of course, the problem with that is we don't know the underlying chemical changes in depression. There was a narrative for a long time which said that depression is caused by a chemical imbalance, which was thought to be something like low serotonin, which most of the public believes or did believe for many years, and that depression can be relieved by taking antidepressants, which increases serotonin in the same way that insulin can fix up diabetes. I guess on one level that hypothesis is false, because if you look at all the studies, there's not a reduction in serotonin in people with depression versus healthy volunteers. But in a broader sense, I think there's sort of a category error happening in looking at why someone is depressed. It's a bit like, saying, I sort of use a somewhat simple analogy with a computer. If your software breaks down, Microsoft Word is not working anymore. Of course, there's something happening in the computer in the circuits. But if somebody walked in and they wanted to open up your hard drive and solder your circuits to fix Microsoft Word, you'd think they're making a category error. They're mistaking the hardware for the software. And, I think the reason why people are depressed and anxious is because of what's going on in their lives. There's childhood, there's the stresses, loss of loved ones, career problems, relationship problems. The research very much strongly backs that up, that then the greater number of stressful life events you have in a year, the more likely you are to be depressed. And so it's about people's emotional needs but not being met, or about them being overwhelmed by stresses. And yes, of course, I'm not a dualist. Of course, what's happening in the mind, is happening in the brain. But to understand it at the level of the brain, I think is making a category error. So just to bring it back to psychiatric drugs, if psychiatric drugs like antidepressants are not fixing the chemical imbalance underlying depression, what are they doing? There's another way of thinking about how drugs work, which is the the drug-centered model. And that's sort of the way we would understand lots of recreational drugs. Drugs are psychoactive substances that cross the blood-brain barrier. They affect the brain, and they affect the way that we think and feel. And a lot of street drugs, are generally experienced as fun or euphorians. And some psychiatric drugs are, like benzodiazepines or stimulants, but other ones are not as positive. And so, a drug like an antidepressant, generally when you ask people who are on the drug, how does it feel? Most people will say that they feel emotionally numbed, that their range of emotions from very positive to very negative has been compressed into the middle. And some people can find that a great relief. So a lot of people will say that their antidepressants were very helpful to them. And I think they're often talking about their emotions being turned down from a 10 to a 3 on the volume knob. And if you're experiencing a lot of anxiety or panic or depression, that can be a relief. It can also cause a lot of trouble in the long term. One of the main reasons people come to the deprescribing clinic that I run is because they feel emotionally numb. They don't feel their emotions. They don't know what they think about loved ones. They've lost interest. So in this disease-centered model, taking a drug for a mental health problem, the drug is not solving the problem. It's kind of superimposing an effect on top of things. And so, an analogy might be drinking alcohol for social anxiety. If you're socially anxious and you drink alcohol, you tend to feel less inhibited and less anxious around other people. Nobody would think that alcohol is reversing the underlying cause of social anxiety. Everyone understands, you're drunk. It's the alcohol being superimposed on your emotions. Nobody thinks that social anxiety is caused by an alcohol deficiency. And I think that psychiatric drugs are probably best understood through that lens. And I think that also brings in other things, that the longer you use psychoactive drugs, like psychiatric drugs, the more your brain becomes accustomed to them. So you get tolerance effects. When you stop them, you get withdrawal effects because the changes to the drug persist after they're stopped. And that, like a lot of recreational drugs can have toxic effects in the long term. And so, for example, for antidepressants, we know they can cause sleep disturbances, memory and concentration disturbances, weight gain, diabetes, emotional numbing, sexual issues, which we know some of which will persist even after people stop them. So I think that's in that lens, can an antidepressant fix someone's misery or their anxiety? I think what it can do is it can often suppress their symptoms in the short term. I think there's an increasing literature about tardive dysphoria, that taking psychiatric drugs long term can actually lead to worsening mood, which makes a lot of sense when you think about recreational drugs, which if you take them in the short term are often euphorians and make you feel good, but in the long term can have negative effects. And so, I think the idea of treating someone's misery in their life with drugs is a generally fraught way of approaching things. So I'm not surprised to hear that somebody's, mood was improved by talking through their problems in a structured way to try to make sense of things, in a way that bombarding them with drugs, never was never successful. I think the whole paradigm is somewhat, misaligned with what's going on.
I'd like to really zoom in on the emotional numbing, emotional blunting issue, because again, this is something that I never really heard about from my mentors in my training. It's not listed as an official side effect as far as I know in the British National Formulary, the BNF. I don't believe it was in the Maudsley guidelines. I was never really warned about it, but anecdotally, speaking to many people in my personal life who have tried antidepressants, speaking to many of my patients, a lot of them report exactly what you say, that the range of emotions narrows. And again, you could see how that could be useful in a crisis temporarily to help someone get through a difficult time. Maybe feeling every feeling might not be a good idea. But one of my main interests is psychotherapy. And in psychotherapy, we kind of talk about how your emotional life is pretty essential, and emotions give you really, really important information about the world and about your relationships. It's really important to feel anger and to be able to integrate it, for example, and use it. even sadness, speaking not of depression, but ordinary sadness, is useful to reflect on negative things which are going on in your life, and you can make a kind of tactical retreat from life and then hopefully come back a bit stronger. Similarly, all the positive emotions, love, joy, gratitude, all this is really important, and you need to get in touch with them so you can cultivate your emotions, learn to triage them. So, of course, having them blunted for a long period of time can really impair people. Um, you've also raised another issue, sort of the hardware versus software issue, and I guess you're primarily making the point that depression is, in light of the evidence, largely due to psychological and social forces. Do you, however, leave the door open for maybe some pathological roots to depression, which might be biological, maybe not in most cases, maybe not in the vast majority, but perhaps in some cases? And the reason I say that is because, of course, mental life is hugely influenced by our physiology. You know, for example, if someone's stops producing thyroid hormone in adequate amounts, they get hypothyroidism, they can become depressed. And I do like to leave the door open to some things which might be going on in the brain, which perhaps we don't even understand yet, which may be causing some percentage of cases of depression. Do you leave that door open for maybe a primary hardware issue, if you like?
So maybe I'll come back to the emotional blunting and answer your last question. So I'll put it like this. So first of all, if something is caused by low thyroid hormones, it's not major depressive disorder, it's hypothyroidism. So it's sort of by definition not depression. I guess the question is, and this is the question that I looked at for 4.5 years in my master's and my PhD, is there something that's more subtle than low thyroid that's causing depression? Some sort of, I spent hours in cell culture hoods looking under microscopes to see, inflammation, stress hormones, neurogenesis. Is there something, it's less blatant causing it? So that was certainly an idea in my mind for many years.
Okay, so I've asked the perfect person.
Yeah. And I think overall, it's impossible to rule out everything, but in my mind, the answer is it would be very, very slim, the chances of that being the cause. And I'll tell you why I think that. By the age of 45, have a guess what proportion of people meet criteria for clinical depression or clinical anxiety. I don't just mean feeling sad or feeling down. I mean MDD, GAD, according to the DSM or ICD. Have a guess.
So you're saying what proportion would have met the criteria for this diagnosis at some point in their lives?
Exactly.
I would say at least 1 in 4, 1 in 3.
So the answer is 70% of people. So the way that I'm getting this is there's a study where they went every 5 years to people. They got a group of people, 1,000 people born consecutively in a hospital in New Zealand, and they interviewed them every 5 years, a bit like that documentary 7 Up. But except this time, much less fun. They came in and asked them the diagnostic interview for mental health problems. And by the age of 45, that's where they're up to now, 86% of people met criteria for any mental illness. And most of that was anxiety or depression. So 70% of people by the age of 45 met criteria for an anxiety or depressive disorder. And this is just a random group of 1,000 people born in a hospital. That's one point. So the first thing to say then is it's extremely common. More of us will meet criteria than won't meet criteria. So the idea that there's something biologically wrong in most people is already a bit suspect.
Yeah, and I definitely didn't want to make that point. The point I wanted to make is, could there be in a very small percentage of cases something going wrong biologically which we don't yet understand?
So then my second part of the answer is, people often ask me, so what causes depression? If it's not serotonin, what causes it? And I say, well, I feel like your grandma would know and my grandma would know, which is, when life is awful, people get depressed in short terms. And that's what the cutting edge research shows. If you look, there's the best researcher in this field is Ken Kendler. He's got a famous study where he looks at thousands of people and he's asked them, tell me what's happened in the last year. And he notes down the number of stressful life events they have. Stressful life event is divorce, job loss, death of a loved one, major physical illness diagnosis, those kind of things. And he graphs people on the x-axis, number of stressful life events from none to more than 10, and risk of depression. And the relationship is like this incredibly steep line. If you have no stressful life events, your risk of depression is very small. And if you have more than 10, your risk is 30 times that of people that have no stressful life events. The other aspect of it is it's divided into personality types. So there's 5 different personality types, from not neurotic at all to very neurotic. Neurotic basically meaning how sensitive you are to stress. So, maybe Barack Obama is incredibly resilient to stress, and Woody Allen, who maybe means nothing to people these days, or Mr. Bean, I'm not sure what the right British equivalent is very sensitive to stress. And so the more sensitive you are to stress, the steeper the line, and the less sensitive, the flatter the line. So in personality, there is a bit of biology. There is a bit of our genetic heritage. There's also childhood, experiences. And so there is some sensitivity to stress in our biology. So people say, you don't think any biology at all? No, I think there is biology, of course, in our response. If you look down at the people that have almost no stressful life events, almost nobody is depressed. So this idea out there that was, in textbooks and is around, of uncaused depression isn't found in research. If you've got people that have many stressful life events, a huge proportion are depressed. I should say this relationship between stressful life events and depression is about as strong as the relationship between smoking and lung cancer. I haven't come across anything that's so strong. So you sort of, and then the third point is, every single study that's looked at a biological marker in depression has found nothing. There's a group in Holland did a meta-analysis in molecular biology, molecular psychiatry, looking at stress hormones, inflammation, neurogenic genes, and it all comes up as null. Neuroimaging, null. So you put it all together, depression is incredibly common. Most of us will experience depression. It relates to the events in our lives, with a very strong gradient. There's been no, gross abnormality found. What makes it more likely? Does it sound like the story of a normal brain responding to life, or an abnormal brain responding to something, that's not in life? And I think the overwhelming story is, this is a story about normal brains responding to stress in life. So can I rule out 100% some sort of biology? I can't. But that overall story is not saying there's some weird, receptor in the brain somewhere that's gone amiss. It's a story of, very commonly for most people, given the right circumstances, they become miserable. The same thing happens to dogs. If you shock dogs, they lie down. If you beat cats, they become depressed. It's almost a mammalian response to adversity. So I guess overall, if I had to put my money on it, I'd put it on there being normal brains in stressful circumstances than abnormal brains.
Yes, and firstly, it's great to have a chance to go over this evidence with you. And secondly, for me, the concept of learned helplessness comes to mind. So again, learned helplessness is something studied in mammals, it's been studied in dogs, and it essentially means something like, no matter what I do, the outcome is the same and it's not the right outcome for me. And when you set things up like that for an individual, and I think many individuals feel like that, it may not be the objective truth. Perhaps they have choices where they're not seeing them exactly. Maybe there are changes they could make. A lot of the work of psychotherapy, in my opinion, is trying to shift the way people might relate to the different difficult experiences they have in their life. But nevertheless, when they feel that sense of, no matter what I do, everything is the same, that's the breeding ground for something like depression. And I would say, again, in medical school, I was often told about the potential case of depression where everything's fine, but they're depressed, like everything in their life is okay. And in my experience, that hasn't been true. That largely when people are depressed,
Exactly,
there are at least 5 good reasons why they might be depressed. And even, things can appear very well for someone on the outside. They might drive a nice car or have a good income, but they might be dealing with some huge existential problem that just isn't obvious to anyone else looking at them. So I would say what you say does corroborate with my clinical experience.
Yeah. So I just wanted to jump on that. Exactly. People always say, what about uncaused depression? What about people who have it all together? And my response is the same as yours. In 15 years in working in psychiatry, I've never met that person. I've never, ever met someone that hasn't, exactly at least 5 reasons to be depressed. So that is my experience as well. I'll just pick up on psychotherapy just for 1 minute. Sometimes people hear me speak and they think, oh, this is a very big proponent of psychotherapy. I am interested in psychotherapy. I've been a patient of psychotherapy. I've given some psychotherapy, and I think it's important. But I also think it's worth zooming out. It's often the context of people's lives, social forces like poverty and inequality and racism and insecure jobs, that is not about the way people think about things, but it is an objective reality. So I think that also plays a very big role in why people are miserable. And that's important not to leave that out.
Yeah, but what I would say to that is that I think people can often think of psychotherapy as just changing the way you think about something, and that's part of it. But I actually think it goes a lot deeper than that, that it's changing the way you think, changing the way you relate emotionally, but then ultimately changing the way you might behave, and in the short, medium, and then hopefully long term, actually change your life outcomes. So I'm a big believer that when psychotherapy is done well, it does result in a concrete impact to someone's quality of life in the real world in ways that can be measured practically. And I don't think that just has to apply to things like CBT. That is not to say, having said that, you're not wanting to diminish these very strong social forces, obviously poverty, racism, other forms of inequality, war, which we're seeing obviously a huge amount about with Ukraine, Syria, Gaza, Israel right now. You definitely don't want to understate that. But to within the degree that someone has choices that they can make and has different options, I think psychotherapy can be a very powerful tool to make different choices than they might have made before.
I guess I'd just say that I think that's true about making choices. I'll just say that a lot of those things aren't within people's ability to choose to change. So, a lot of, exactly as you say, all these social forces, it's not about people making bad decisions or making the wrong decision. They don't have the opportunity, they can't change some of those large social forces. So, but I think psychotherapy definitely has a role to play. I agree with you.
Yeah. So all of this being said, I mean, clinically, how do you think about depression? Is it still a valuable diagnosis for you, a valuable concept? Do you apply it to patients that you see?
I think it's got significant limitations because, it takes away from the complexity of something. People can become depressed for all sorts of different reasons, and you lump it all in the same box, the same 3 words, and you go to a some kind of list of different drugs or treatments or even therapies that sort of one size fits all. I don't think that makes sense. I guess it makes more sense to work out why is somebody in that way. You said you come across people with 5 different reasons. It's good to work out what those 5 reasons are so you can try to at least help them see that, or to help them, if you can, solve those problems. And so I think it's much more sensible, something like formulation. Why has this person ended up in this place, than to use a diagnosis that doesn't have any biological meaning that we've found, or really any kind of prognostic meaning or treatment guidance. So I don't think it's a very useful concept.
One thing I did want to mention actually is once, obviously depression to most people, I think when most people think of depression, they think of mild to moderate depression. And of course, as psychiatrists, we see more severe forms, and that might include severe psychomotor retardation, which means real slowness and limitations to one's spontaneous mobility. They might eat less, drink less, to the point of dehydration or starvation. Like, this can happen. And how should we understand that? Is it that their low mood has gotten to the point where then some biological mechanisms do start to kick in and generate a positive feedback loop? Is that a good way of understanding it, or how do you understand that problem?
Look, I'm not sure I've got all the answers here. All I know is that at different points when I've been depressed, I've been psychomodally retarded. So I would have definitely met the criteria for severe depression. I've been prescribed ECT at different points. I didn't take it, but I was prescribed it. And I guess the thing that's been most useful to me is to make sense of why I was depressed, what emotional needs were not being met, what things in my life were out of line, out of whack. So I kind of think severity is a bit of a funny concept in some ways. So if a person's partner leaves them, in awful circumstances because they cheated on them and they betrayed them and they've left their family, if that person screams a lot and cries a lot, and lies in bed more than somebody else in the same circumstance, we would say that's more severe depression because on the PHQ or the HAM-D it's more. But sort of in some ways, does that really help you work out what to do with that person if they've got 25 out of 25 intensity of symptoms versus 6 out of 25? They've both got a severe existential problem with who they are. They've lost their attachments. They feel betrayed, they feel ashamed, they feel lost. The issues are the same. If they scream louder, does that make it a different condition? So I kind of still think that understanding what are the existential circumstances that's causing somebody's, mood makes the most sense of it, rather than looking at, how severe it is. Although I understand, of course, that if someone's not eating and drinking, you now have a much more immediate problem than their existential issues because life is being risked. And I understand that there are extra things that have to be done in that situation. But I do think that some people get into very bad places, exactly some sort of downward spiral that can lead you there. And I guess I can't point to research except to say that I've been in that position. And it was existential issues that got me there. So I think that it's just a property of the human mind that it can end up in such dark places. And for me, the solutions were largely existential and not biological. Although I know that I think you've probably put your finger on a very important thing. When you see someone in that state, you think biology because it looks very biological. This looks like an illness state. I think when people talk about mild to moderate depression, there's much less of this. People say, everyone's been in that state very, commonly people can recognize that, whereas this looks something different. I think there are ways to get there, that don't necessarily mean there's something being broken biologically.
Yeah, I agree with you. But what I think it'd be really useful to know what might happen between that moderate and that more severe stage. And I think there's this idea, it's applied to many things, not just to illness, but that things go wrong very, very slowly and then all at once. And I wonder if some sort of physiological cascade might be involved in that transition from more moderate, what we would call more mild to moderate, to more severe depression. That wouldn't change really anything of what we've said so far, the ultimate causes, the existential problems. And certainly in the medium to long term, those would need to be addressed. But I often find in psychiatry, the general gist of treatment guidelines is that more biological interventions tend to be more appropriate in more acute, severe situations. Do you agree with that notion? So, for example, taking the idea of something like an antidepressant, do you think that might be appropriate in a case where someone is in hospital with their low mood, bedbound, reluctant to eat or drink? Is that a situation where perhaps something like an antidepressant or ECT, as you mentioned, might be useful?
What I find useful actually is to talk about dogs. Sorry to sidestep. I feel like there's much less confusion when you talk about dogs and about people. If you went into what is it called? A pound. That's American. I don't know what the British term is. A kennel or whatever. Where dogs that have been, left by their owners are taken somewhere. If you saw a dog, that had all its fur ripped, it was bleeding, it was lying in a corner, it was, banging its head against the kennel, it was, self-harming, ripping itself, lying down, barely eating. What would the dog need? I think we would all say the dog needs care. It's been there because it's been abused, it's been whatever, thrown around. It needs care. It needs to, have its fur fixed, given food, make sure it feels safe. And I don't know about dog prognosis, but it will probably get better over time given that sort of thing. Is there a point at which that dog needs drugs or ECT? I just sort of use the same frame with people. I think people get into very, very dark places. Yes, as you say, psychomodally retarded and very negative and suicidal. But I still think, I still think the same thing applies to the beaten dog. For the severely depressed person, I still think the same sorts of things, care and attention and trying to solve their problems, is what's going to make a big difference. I get doctors have a lot of pressure on them. They think that, if someone's life is imminently a danger, they want to take very, robust action. But I still have in my mind that beaten up dog.
Mm. Do you think as doctors we're just far too conditioned for seeing drugs and other similar biological interventions as the treatments for people's problems, and we just need to get out of this operant conditioning we've become victims of?
I mean, in short, yes. I mean, of course, that's the basis of psychiatry, that we're doctors trained in biological treatments, applying it to mental disorders. And the premise behind that is that underneath all of these mental disorders will be some kind of brain or biological problem, and therefore it makes sense to use biological treatments. And so, once you're a doctor, that's what you're going to do, because, in the team you're in, you've got social workers for social things, you've got psychologists for, psychological issues. And so you're left with the biological treatments as being the main purview of doctors. Of course, there's some overlap with therapy, of course, but yes, that's one of the issues here, that psychiatrists are, embedded in a basically biomedical paradigm, and therefore they apply biomedical solutions to problems, I think, which in many cases are not best understood as biomedical issues. And that is why I think that a lot of harm can be done with that kind of approach, and why it can be also highly ineffective, like the case you gave with the psychotherapy patient.
And going back to the beginning where you highlighted this difference, this gap between clinical guidelines and research and anecdotal information from patients on forums, and I myself have often found you can get really valuable information about what the experience of a drug is like from a forum or even from YouTube, someone talking about their first-hand experiences. Super valuable for me as a clinician who hasn't really tried psychiatric drugs to get that kind of qualitative information. Why do you think that gap exists? There's been a lot of research done on psychiatric drugs. Why is there such a profound gap? Why was I not taught about emotional blunting in my training?
Yeah, because of money, basically. Obviously, the pharmaceutical industry is either the largest or the second largest industry on earth, between fossil fuel industry and the tech industry, and they produce most of the research that exists. I know antidepressants particularly well. They produce 97% of the research in that area, and they produce research that's not aimed at improving public health, but in improving sales. And so often the premises of the studies that they conduct are to show their drugs in the best light. So I'll give you, a very specific example of the area I've just talked about. Why do withdrawal effects appear to be mild and brief in the literature, but they're severe and long-lasting in real life? That's because drug companies did studies of people who had been on antidepressants for 8 weeks. And if you stop the drugs after 8 weeks, most people have mild and brief symptoms. Not everybody. Some people already have severe symptoms after just 8 weeks. But what the drug companies do is they produce many studies like that, and they printed them out and they sent them around to the key opinion leaders in America and the UK and Europe. And it was repeated so much it entered the guidelines. So the NICE guidelines for many years said withdrawal effects are brief and mild. Of course, ignoring the fact that people are on these drugs for years and decades. And the longer you're on the drugs, the more severe the withdrawal effects are. So to me, it's a bit like a car company crashing its car into a wall at 5 kilometers an hour and saying it's safe, and ignoring the fact that people are driving around at 60 kilometers an hour. And in general, that's what happens. Drug companies are kind of marking their own homework. So they are conducting studies that are set up in all sorts of different ways that we can talk about, that make the drugs look more positive than they really are and minimizes the harms. Then they pay professors of psychiatry at King's or at UCL or at Oxford, Cambridge, Harvard to give lectures about those drugs. Those professors then set the exams, they set the Royal College of Psychiatrists learning modules. And so it's been described as doctors are actually, they think they're very independently minded with critical thinking, but they're actually existing within an entire stage managed situation where the studies being produced, the people telling about the studies, the people setting exams are all kind of part of a system where they're all influenced by, large amounts of money from industry. And so I think that's why it's so jarring when you go talk to actual patients about what their experience is. And of course, doctors have been taught, that's anecdotal, but what's in the textbooks, that's evidence-based medicine. It is in a very narrow sense. When they look at short-term studies, they bias the studies to be positive towards the drugs. It's a very misleading slice of evidence. And so I guess that's why I think that's why there's such a big difference. That's just, I'll give you an example with withdrawal, but that's true for the effectiveness of antidepressants, their harms, and a whole lot of other psychiatric drug classes where the evidence is often skewed by financial interests.
Have you received much criticism or pushback, whether it's from pharmaceutical companies, major research institutions, prominent psychiatrists, about the kinds of things that you're talking about?
I've received a range of feedback. So since I've started publishing about how to safely stop psychiatric drugs, I've received 22,000 emails now and counting, mostly from patients, but also from clinicians asking me for advice on how to safely stop their drug or their sister's drug. Some of the more interesting emails I've got emails from psychiatrists asking how to stop the drugs that they're on. I've got emails from drug company executives asking me to help their sister or their wife stop drugs they can't come off. I've been contacted by researchers in the field. So I think that's an interesting snippet. Then in the public domain, I've had a lot of psychiatrists say, they've experienced these issues through their patients or their families, and they want to know more about it. And then, yes, I've had some very, negative, confrontational interactions often with the key opinion leaders. So these are, the academic psychiatrists who are, often at Ivy League or Russell Group universities, often who have close relationships with drug companies. They get paid a lot of money every year to become the spokespeople of these companies, and they've been very critical, of course, of my work. They have said, the evidence-based literature is much more important than anecdotal literature. They tend to ignore the studies that show that issues develop over the long term, and they've often, I think, yes, they've been very, very critical of the work that I put out, to the point where some of them have, tried to get papers that I published retracted, said very critical things in the papers, tried to get me fired from my job. So been quite aggressive in defending their interests.
Wow, okay. So I suppose and you can fill in the gaps where I make gaps, but the response to their criticisms would be something like a lot of the research showing that antidepressants are minimally risky, that research itself is biased. There's a lot of research not showing any real clear biological cause for depression. There isn't enough research looking into all of these things that people are reporting anecdotally, that patients are reporting anecdotally. Did I leave anything out there?
I mean, I guess I think it's gone past anecdotal things now. There's more and more research looking at that finds that withdrawal effects from these drugs are much more common, severe, and long-lasting than we thought. Yes, minimizing long-term harms, but yes, your list is a pretty good starter list of the issues that have been overlooked by researchers. Yes.
And in just the few minutes we have left, perhaps you could, we'll direct listeners to a place where they can learn more, but perhaps a few general tips on coming off antidepressants. What might be a few principles you might outline?
Sure. So there's basically three major principles to coming off antidepressants safely, and this is true not just for antidepressants, but for any psychiatric drug. It's easier to do it slowly than quickly. So it's easier to if you take it over months and sometimes more than a year. Sometimes people need years rather than weeks or days. And that's because it gives your brain time to readjust to the drug not being there. I use the analogy of, if you're on the 10th story of a building, if you jump from the top to the bottom, it's very quick, but you're going to get very hurt coming off it. If you walk down step by step all the way to the bottom, it's going to take you a lot longer, but it's going to cause your knees a lot less pain. And the same is true for coming off psychiatric drugs. The second issue is you've got to do it at a rate that you can tolerate. Everyone's a little bit different. There's some known risk factors. The longer you're on a drug, certain drugs have a higher risk than other drugs. Higher doses have a small increased risk. But it's very hard to predict exactly how someone's going to react. And so there's a bit of trial and error. So you've got to go at a rate that you can tolerate. And an example that I give is something like altitude sickness. If you go up too quickly up a mountain, your body can't handle the lower pressure and you develop altitude sickness, headache, dizziness, feeling crappy. And the best way to fix that is to go back down again, to recalibrate to that pressure, and then go up again more slowly to the peak, so you don't get the same altitude sickness. And the same is true for coming off psychiatric drugs. If you feel withdrawal effects, you should pause, go back a step, wait for it to settle down, and then go down more slowly. And that's a bit of trial and error. And the last principle, which is it's easiest if I show can I show a graph, or is this is for a podcast?
Yeah.
So I'm just going to show you these graphs. You're seeing it's basically there's a graph. It's got venlafaxine on the x-axis, and it's got effect on the brain on the y-axis. It's actually serotonin transporter effect, but you can think about it as effect on the brain. And this is going to explain why it's very hard to come off the last few milligrams. So this is based on neuroimaging of the effect of these drugs on the brain. And what it shows in the black line is the relationship is not a straight line. Doubling the dose doesn't double the effect. So going from 75 milligrams of venlafaxine or Effexor to 150 milligrams of venlafaxine barely increases the effect on the brain at all. And even a tiny dose like 10 milligrams actually has about 3/4 of the effect of 300 milligrams. Even 5 milligrams has half the effect of 300 milligrams. This relationship is much steeper than you would guess. The reason why this relationship exists is because of the law of mass action. And it basically says when there's not much drug in the system, all the receptors for the drug are open for business. And so every milligram of drug has a big effect on the brain. A bit like the game of musical chairs when there's not many people in the game at the beginning. As there's more and more drug in the system, each milligram of drug has less and less cumulative effect until you get this law of diminishing returns. And so if you do what most doctors recommend, which is they might say, well, the smallest capsule of venlafaxine is 37.5 milligrams. So you should go say from 150 to 112 and a half to 75, 37.5. The first reduction is very easy to make for most people. The next reduction can be a little bit harder. The third reduction can be a bit harder, can be quite unpleasant for some people. But the last reduction is like jumping off a cliff. It's actually about 30 times harder to go down from that last capsule of venlafaxine to zero than the first reduction. And so people experience incredibly severe symptoms in this last reduction. And doctors who are unaware of this relationship will conclude that they must need the drug, that they're relapsing, that they've got very severe symptoms. What makes more sense is what I've shown in this right-hand graph, is to go down by even amounts of effect on the brain. So I've drawn 4 horizontal lines that are equally split apart. And so you can see that to go down from about 150 milligrams, you need to go down by smaller and smaller amounts down to very small final doses before stopping, like just a milligram or two. It's kind of like climbing down. It's like walking down this path. You need to go very carefully at the end. And so I've sort of drawn here, I've turned that graph into tables. And so here's an example of coming off venlafaxine in what you might think of as a pharmacologically rational way of doing it. So it's easy to start reducing at the beginning. When you get down to lower doses, you need to go down to very small final doses before stopping. And this is actually a faster taper, and some people will need even slower tapers. This is actually an excerpt from the Maudsley Deprescribing guidelines that we publish that goes through every drug that's on the market for an antidepressant, benzodiazepine, Z-drug, or gabapentinoid, and shows how to reduce it safely. And so that's the final aspect, is you need to go down by very small amounts. And in order to do that, you'll see that, for example, I mentioned a lot of liquids here, and that it's impossible to make up these small doses using widely available tablets or capsules. And most people will need to use a liquid version of the drug, or other tricks that are off-label, things like opening up a capsule of venlafaxine and counting the beads inside, or getting a compounding pharmacy to make up a liquid or capsules, or sometimes you can just crush up the tablets and mix them with water to make up these small doses. And that's the way to come off these sort of drugs safely.
Excellent. So that's a really useful explanation as to why coming off can be so counterintuitive, because I have actually encountered that with patients as well, that coming off that last bit, even when it comes to opioid replacement, like methadone and so on, can be really, really tricky. Okay, Mark, thank you so much for talking to me today. There are a few other topics I'd love to talk to you about at some point in the future, like tools for treating depression, neuromodulatory treatments like TMS, psychosis, bipolar, perhaps topics for the future. But in the meantime, thank you very much for joining me today.
Interesting talking to you too, Alex. Thanks very much.